if I could say by explanation, I'm ex-Philips. I left at the end of March. But when I agreed to give this talk, it was when I was under the salaries of Philips. This work relates to some funding we got from Innovate UK, SBRI, and it's all about how to understand the problem before you come out with the technology. As the preamble said, I've been doing this stuff for quite a few years now, and I'm generally surrounded by a load of highly intelligent geeks who can do amazing things with technology. And then you try and drive it into the NHS and the like, and you have problems. So what we did in this Innovate UK study, and Professor Price over there is one of the ones who advocated we take this approach, along with the late Professor Rick Jones at Leeds, is really understand the problem. In NHS, often you're dealing with silos of pharmacy, pharmacology, whatever, any ology you like. And in this case, we thought, why don't we take it from a patient perspective so we're truly capturing all the issues, benefit, costs and hassles of the care pathway for the patient. And then we use those insights to develop our service. We took chemotherapy. Why? Because we were looking to monitor patients. And the NHS is probably adverse to spending money without getting a return. And the reason we chose chemotherapy as a model for monitoring patients is, unlike certain patients who will be on monitoring for 5, 10, 20 years, hopefully a patient with cancer undergoing chemotherapy will only have that treatment for 6 months. So, i.e., in the same budget year that you're monitoring, they're getting the treatment and hopefully realizing the benefit. For those of you who don't know, chemotherapy, systemic chemotherapy, is when your body is given a drug that kills rapidly dividing cells, cancer being the primary target, but other cell matter in your body like bone marrow, your hair, the lining of your mouth, is also rapidly dividing and will also be destroyed by the chemotherapy, which can cause issues. Chemotherapy given day one, I go home, I tough it out, I feel sick, I'm vomiting, I feel feverish, and after 21 days, we hope my body's recovered, and I go back and have the next shot of chemotherapy. So that's, in general, what should happen to a patient on chemotherapy. What we decided to do was to interview, probably getting on for 400 patients in Europe and America. And these are the snapshots, and these are verbatim quotes we took down to try and get the true impact of this treatment on a patient. And unlike certain chronic diseases where maybe lifestyle is impacting how the patient feels, like diabetes, overeating, lots of beer, Snickers, etc., in chemotherapy, the patient is often feeling sick because of the drug that's been put in their body. They get fuzzy. They find it hard to focus. Any of you who've been unfortunate to know people who've had chemo, they can't concentrate for too long. As one of my colleagues said, it's like swimming in a sea of semolina. You just can't remember things. You get confused. It's a stressful time. You have a heart attack, you go to hospital, they treat you, you come home, you recover. In the case of chemotherapy and cancer treatment, you get the treatment, then you're home and you're toughing it out with your parents. So cancer tends to be often a familial issue as well. The children see maybe hair loss, mummy not feeling too good, daddy in bed all the time. And also management of the children. Who's going to pick them up from the hospital today? Who's going to make them supper? Because I'm getting chemotherapy today, and as soon as I come home, I'm going to bed. And is the chemotherapy working? Is the cancer going to kill me? Is the chemotherapy going to kill me? This is what we heard time and time again from cancer patients. Now again, what our proposition set out to do is not to address these issues, but it helped us understand how strongly the patients felt about what they were going through. And it's a long journey. Say if you had breast cancer, that could be 6 cycles, 21 days, assuming the therapy works. It may be the regime you've been put on hasn't worked, so you put on a second line of chemotherapy. So some patients may be on chemotherapy for 6, 9 months, but they've told their kids at the end of chemotherapy, we're going to Disneyland, but then it gets delayed. And the symptoms. All patients should be told, you're on chemotherapy mid-cycle. When your bone marrow is being depleted, you may get an infection that could be life-threatening. Look out for that. But the patients who are undergoing that, they say, well, but the chemotherapy is making me feel terrible anyway. I don't know if any of you drink or any of you had a cold, but if you have a hangover and a cold at the same time, it's difficult to differentiate the two sets of symptoms. It's the same with chemotherapy. The chemotherapy is a toxic drug in their body, makes them feel lousy. On top of that, they may have a life-threatening infection. How do you discriminate between the two? And the time when they go to hospital. The patient would go to hospital, they'd have their blood count taken to make sure that their body's recovered enough before the next chemotherapy, which is going to blast their blood cell count. So they wait for the phlebotomist, they wait for the results that get sent to pharmacy, who may be stacked up trying to make all the other toxic chemotherapy for the patient. So that patient may have been in the hospital at 8 in the morning or 9 in the morning after driving 1 or 2 hours. They may not start getting the infusion of the chemotherapy till mid-afternoon, and that infusion could take 3 to 6 hours. So it's the hanging around. Any of us who've wasted in a hospital, it's just like, it goes on, it's horrendous. And the support network, and also the scheduling. It's if I go to hospital and I get told I can't get my chemotherapy because I'm still immunosuppressed, I've got a low white cell count, I've got to get my neighbour to bring me back to hospital the following week. So they've got to take a day off work. I've got to arrange childcare and the scheduling. And the communication. The patient for 21 days may be at home, confused, not knowing what's going on. Is the cancer being treated? Am I going to get through this okay? And it's the reassurance factor. So in a way, this is a summary of the patient's perspective. They feel isolated, confused, worried about treatment delays. If the treatment's delayed, does that mean the cancer is going to continue growing? So I'm going to have further therapy. So that was the perspective of the patients in America and in Europe. So then we thought, right, it's not nice and they don't like it and they really would like something done to it. So we then looked at what's the quantitative issue? So they've given us the qualitative, life's not good when you're on chemotherapy. So we looked at the UK hospital episode statistics. So this is what a cancer patient is told. You're going to have cancer treatment, you're going to go home for 21 days, you're going to have cancer treatment, you're going to This should be like the M1 on a Sunday morning at 2 o'clock midsummer's day. In actual fact, it's more like Spaghetti Junction. 38% of patients going through chemotherapy will be hospitalized at some stage. Non-elective admissions, them being admitted to hospital wasn't planned. It's because they may have fever or their sickness or whatever. We did some work at Leeds where they've got a 10-year patient database, very detailed patient database, where we mapped out all the cases, all the clinical situations where that patient on chemotherapy at Leeds may go to. This is the ideal. So they have chemotherapy, they come home, no contact with anybody, 21 days they go back and have it. A number of them, a high percentage, will be calling their GP saying, I'm feeling feverish, or they'll go to hospital and not get their chemotherapy. But surprisingly, as I said earlier on, 38% are being admitted to hospital with maybe fever and the like. So this idea of simple 8% are the only people getting it. We then looked at when patients get sick. If they get sick on first cycle, do they then, is that it? Or if they miss getting sick, here, no admission, 88%, does that mean they've got a free ride? But no, you'll see, of that cohort there, 20% second cycle. So it shows that if you can get through your first cycle with a hospital admission, doesn't mean you're home free. And then we just looked at now the cost. So we've gone from the patient side, we're now trying to put it in a quantifiable perspective to the chief financial officer of a trust who's going to buy the service or the product or whatever. Again, this is just an example, but it's trying to understand the patient problem and the problem, how it manifests itself to the hospital. So this is some of the work we carried out where patients were costing $250,000 in over 10 months at a hospital in the UK. Unplanned, unnecessary admissions. Here we tracked, I think it was about 6 patients at Leeds. The first 6 patients, would you mind being tracked? Fine, okay, you're on board. And we just tracked where they went during those weeks. Can you keep a diary? Tell us what's happening. And this tells you what's going inpatient ward travel to hospital. Just to give an idea of the inconvenience to the patient, but also the impact on the hospital. This is one patient and their journey to and from. The value added, the green dots highlight there was a valued episode of care. The checking, the transport. So I make that 9 of probably 30 excursions to that hospital. Only 9 of those excursions had true value. When you then cost it, so this column here, the cost based on admissions, this is what the hospital would have incurred in costs, £50,000 for those 5 patients. And the middle column is what the hospital would have been paid. So I make that about a 3-to-1 split. So they're incurring all those costs, in quotes, I would argue from inefficient processes, but they're only getting paid £15,000 for it. So from the clinical perspective, I'm having to delay and reduce chemo. There's hospitalizations. I mean, you can read it, but the whole thing is a waste of a limited resource. And from the payer's perspective, some of these treatments, these patients are getting $70,000 a year. They come to the end of that cycle and they've found it hasn't worked. And it's had costs of emergency admissions. So they then have to try and repeat with the new therapy. So escalating. So we then ask now specifically, again from the insights, what are we going to develop that addresses these problems? So this is what a financial manager of an NHS trust said. Because of these non-elective admissions, I think it was costing him nearly £12 million a year in costs. His tariff was £10 million, apart from the impact of these patients blocking beds. But he reckons it was costing him up to £750,000 a year. What we said is, when we talked about home monitoring of patients on chemo, what do you think it could do? And again, here you can see his figures based on his assumptions of how he runs his hospital. So that was a financial perspective of the problem now and what he sees is an improved care model. This is a clinician, head clinician up in Leeds, how monitoring white cell count, looking at patients, tracking them. This is the staff card that everybody carries at Bexley Wing at Leeds, because it's so important, this risk of sepsis during chemotherapy. And this is the patient card. If you're feeling sick, call us, come in. So this is what we've proposed based on the wastage. If a patient was put on a home monitoring or a remote monitoring system, doesn't have to be home-based, and the list on the right is what the clinicians would want to see on a regular basis, white cell count, temperature, and the like. That would be then inserted to the oncology team on a remote basis. They could then provide feedback to the patient who's testing or the nurse is testing their white cell count. And proactively say, take antibiotics, you're mid-cycle, it looks like you're getting a fever, or don't come in for your next chemotherapy because you're not ready. So it improves the whole cycle. So we developed this care model on a virtual basis based on what the clinicians and the patients were telling us. So the patient, we're reducing the wasted journeys to the hospital. To the hospital, we're reducing the wastage of drugs, the waste of clinics, and improving efficiency. So the objective we had was, when a patient goes to hospital, they get treated. They don't have a quick check and go home, you're not ready. And so we're utilising more effectively the resources of the hospital and reducing the wear and tear of a very fragile patient. They're already immunocompromised. They don't want to be in a hospital for no need. So this is what an oncologist said he sees the future care pathway based on what we've worked through. He's getting a clinical feedback and toxicity of the drug of this patient on a real-time basis. Unnecessary trips are avoided. He can identify high-risk patients early on and prophylactically treat them with antibiotics, growth factors, and increase dose intensity if he wants to. Now, this work was not carried out by me, but this august group of people here, and I apologise, I've missed off the late Rick Jones, professor up at Leeds, and he, along with Professor Chris Price, were the two guys who kicked all this off and said, understand the problem. So that's all I'd advocate. If you're looking to do medical device design, try and make sure you involve all the stakeholders, but also involve the actual care pathway you're looking to improve or change. Thank you.